Thank you very much, and thanks to Liad and Jawad and Denise and Terry and Keith for those wonderful opening remarks. I don't know about you, but I've got a problem now because I'm going to vote for Keith Farrell. Thanks to the Boston University School of Medicine for letting us use this beautiful facility, and thanks mainly to all of you for coming tonight. I'm so excited to see so many of you here advocating for this needed change. With energy like this, we're going to do it. We're going to make single payer a reality in this Commonwealth. So I'm running for governor. I would love you to join me. I want you to join me in making Massachusetts the progressive beacon that this country needs badly. I want you to join me in fighting for the values that I think underlie the progressive agenda: social justice and equality and compassion. It's fundamental to the way we organize ourselves and build our communities, and in working for an economy that includes absolutely everyone. For tonight, I want to start, though, with the basics. The basics are that healthcare is a human right, period. For much too long, this nation has been the only Western democracy that has failed to make good on that promise. Now we are en route. Do not let the lies trick you. The Affordable Care Act, Obamacare, is finally putting us on the pathway toward promising every single American man, woman, and child that they no longer need to be afraid that they won't have care if they need it, and they won't face bankruptcy from getting care if they do need it. Bravo. And bravo, Massachusetts, because we got there first. In 2006, we did it, 8 years ahead of the rest of the nation. We made healthcare a human right. And we're never going to go back, never. But now we can lead again, forward. Again, we can be a beacon for this nation. You see, when it comes to health care, we aren't done. Coverage alone, as Terry said, is not enough. We need to promise that, but we need a bigger promise. The promise of better care when we need it, better health for the population, and lower costs that we can afford without doing real damage to our public resources, to our working families, and to the vitality of the businesses in our Commonwealth, large and small. That's the promise I call the triple aim: better care, better health, and lower cost through improvement. That's what I've worked for 3 decades. But that takes a new healthcare system. It takes one that's going to direct every single ounce of its energy, every nickel of its money, every nickel of your money, toward meeting the needs of people, our needs, relieving the burden of illness and injury and disability, and not waiting for trouble, but keeping us healthy in the first place. We need to make that as a guarantee. It's got to be a guarantee to every person. Most urgently, I must say, and most importantly, a guarantee to the least advantaged among us: children, elders, people in poverty or near poverty. Liberty and justice for all means health care for all. And all means all. This nation has one healthcare insurance system that actually does that, but it's only for elders. It's Medicare. It's a step that we took as a nation in 1965 that ended for our seniors the fear that they aren't going to have health insurance. And more than that, it established a publicly accountable, transparent system of insurance, of coverage, to serve them. And for 17 months, as President Obama's administrator for Medicare and Medicaid, I got to lead that system. I led Medicare. I got to fight every single day for the interests and the well-being of nearly 50 million people. And I did that with an administrative budget, by the way, overhead rate of 1% of what we spent on their care. Of every Medicare dollar that we spent, 99 cents, 99% of it went for care. Elders have that now in America, and just you try to take that away from them. If anyone made a move to end Medicare now, 50 years after it began, there would be such a public outcry, so fierce, the idea would be drowned out instantly. Don't you touch my Medicare, they would say. That's what they do say. That's what 50 million people say. But what about the rest of us? Who's got our backs? Or more accurately, who's got your backs? Because I qualify for Medicare. I'm the first administrator that qualified for Medicare, and don't you think of touching it. The politicians in Washington had a chance. They backed away from the next logical step toward publicly accountable health care coverage for everybody. They rejected a single-payer plan. They even rejected a public option as a plan in the heat of the Affordable Care Act debate. The vested interests of the status quo, insurers, and many others, they put up a fight. They fought to preserve a complex, unaccountable, opaque system of payment, the system we have today. And the result, it's waste, it's confusion, it's complexity, it's opacity. It's waste because the private sector insurers spend over 10% of your premium dollar on overhead, most over 15%, not 1% of your money, like Medicare does. That wastes your money. That comes right out of your pocket. Confusion and complexity because your doctor, your nurse, your hospital administrator, and you spend hours of time and billions of dollars sorting out coding systems and billing rules and approval processes and coverage determinations. Your doctor doesn't get to ask first, what do you need? Instead, she asks, what's your coverage? Who insures you? Just try to understand that. Try to see how far you get. Try it. Give your insurance company a call. Ask how they decide and who decides that you can have test A but not test B, or that you can have drug X but not drug Y. And then, if you do have the coverage, who stands up for your interests? Who goes to the mat to make sure that your care is safe, that it's world-class, and that it's available, that it respects your choices, that it respects your culture and your preferences? Medicare does. By law, it has to. When I ran Medicare, I spent days and days implementing and overseeing surveys and studies of care that Congress requires us to do to make sure that the care is as good as it can be. I helped develop and launch the largest patient safety program in the history of the world, the Partnership for Patients, it was called, to help hospitals reduce injuries and errors in care all over the country. And then there's opacity, the lack of transparency. Who can see into the windows of today's healthcare coverage industry? Only one system of coverage in our nation is required by law to release data on health care's performance, to explain in detail how it arrives at coverage decisions, to tell everyone how much it's paying and to whom it's paying it, and that is Medicare. But they say it can't be done. They say Medicare for all can't be done. I say they're wrong. They said we couldn't cover everyone, and we did it in 2006. And now we can prove the naysayers wrong again. We can create and we can manage a simplified, transparent, efficient, and fully accountable healthcare payment system, a single payment system in Massachusetts, and we can make it work for the people. There'll be critics, especially people benefiting from the status quo. They will mouth words about government takeover of healthcare. Don't you believe them? Under a Massachusetts single-payer system, we can, and I think we should, keep the exciting, the productive pluralism of healthcare provision that we have in this Commonwealth. Hospitals and clinics and doctors, integrated systems of care, they can be, and they should continue to be, independent. Some will be public, some will be private. When it's useful, they can and they should compete with each other. What will be new with the single-payer system here is that now you, the people, you have a potent way to speak with those who give care about what you need, about what you want, about what you will pay for. You can say that mental health services are deficient in this state, as they are, and that you want that fixed. You can say that you need health care to defeat the epidemic of substance abuse that's killing our people. You can say that you want energy and money devoted to prevention, to real prevention. You can say that you expect care to be safe. You expect care that respects cultural and linguistic diversity throughout our communities. You can say you want to be home. You want care at home. And you want better respect for home care workers. And we can all say that we want every single nickel and dime of our hard-won wages that we spend on health care to buy health care and health. Not paperwork, not billboards, not corporate palaces, and not confusion. So let's lead Massachusetts. We can show this nation a pathway to health and victory over illness, a pathway to what healthcare really should be for patients, for families, doctors, nurses, and the hundreds of thousands of Massachusetts healthcare professionals who really want just to be able to do the work that adds meaning to their lives and health to your lives. People often ask me if I'm a one-issue candidate, whether I have ideas for the future of our Commonwealth beyond healthcare. My answer is, of course I do. I want our education system to be the envy of the world, and I will fight for that. I want to end child poverty in this Commonwealth. And we'll do it in a decade. I want to end hunger and homelessness, for which there is only one number that's right, and that is 0. I want this Commonwealth to have the most ambitious energy and environmental agenda in the nation. And I want jobs. I want jobs in an economy that gives absolutely everybody an opportunity to thrive. But I will tell you this, if you care about education, if you care about jobs, if you care about transportation, if you care about ending hunger and homelessness and poverty, then you have to care about health care. If you think that all means all, and I do, then we had better have in that corner office a governor who understands what great health care looks like. Health care is now 42% of the state budget. That's gone up 59% in the past decade, and every other line item is down. Without reform, without serious reform, without bold reform, healthcare in Massachusetts, like healthcare in the rest of the nation, is going to continue to erode possibilities and investments from the public sector and the private sector alike. It'll hurt the public sector and it'll hurt the private sector. But we can have the triple aim. We can have better care and better health and lower cost all at the same time if, and it's only if, we commit to shaping a system of care that's focusing every step of the way, every resource it has, on the needs of the people that it serves. And the front door to that change, a crucial step on the way to health, is a financing system at last that makes sense, single payer. It's Medicare for all. It's right, it is possible, and it is time. So join me. If I'm your governor, we will go to that better place. We'll make Medicare for all a reality in this state. We will be, as we have been before, an example, a beacon of reason and compassion and justice for a troubled nation. Now, I want to hear from you. I want to know what you think, so please ask your questions.
The first question actually comes from the internet earlier on today. The question is from Sam in Boxborough. Don, you claimed that you were instrumental in implementing Obamacare, clearly a failure. Why should we trust the government be the tool to fix a health system that the government broke with Obamacare?
First, don't let the lies deceive you. Obamacare is a majestic step toward health care as a human right in this country. It needs you and me and everyone to speak up for it. It is and will be a success for this nation. rollout was awful. It was badly managed, it hurt people, and now at last it's finally being fixed. I favor single-payer health care well managed, not poorly managed. And I am confident, with confidence in the government offices and proper cooperation with the private sector, we can make single-payer work here beautifully.
Don?
Hey.
Hi. Can you walk us through how we get there? And I'm coming from the perspective of, I've seen the insurance lobbies and I've seen hospital lobbies. And there's a lot of finger pointing in both directions. And so how is it politically achievable? You know, and maybe I'm getting a little legalistic here, but how can we do it? What are the interim steps we take to get there?
Yeah.
And if I can also suggest, I know Maryland is experimenting with a, they're looking at the cost of providers, and we have that issue in particular in Massachusetts. And then, of course, we've got the insurance complexity. So if you can walk me through and educate me, I'd appreciate it.
Well, I'm not claiming it's going to be easy, but the answer is mobilization. The common interest we have in this state in moving toward a simpler, more transparent, more accountable payment system, one that allows us to use payment as a tool to achieve the healthcare system we want, the common interests are vast. We are almost all better off. And by the way, that includes providers of care. Because follow a doctor or a nurse through her day or his day. Follow an administrator in a hospital trying to make the hospital work right. You will see the wages of complexity and the lack of transparency confounding that work every day. I want it simpler. I want to stand up with the providers of care in this Commonwealth on behalf of the patients that they wish to serve, and this is the simplest way to do that. Of course, this is change. For the insurers, it threatens the business models that they're used to say the least. There'll be others who will claim that this is it's too much government. I say no. This is us standing up for what we want in terms of our rights. And when we mobilize, when we have a public that's as energized as you are, the legislators will listen, and the forces of the status quo will not prevail. You've seen the lobbying combat that quell discussion of single payer at the national level. I saw that too. What I've also seen in the living rooms and the libraries and the conversations that I've been engaged in throughout this Commonwealth in almost a year of campaigning now are heads nodding. People tired. They're tired of the confusion. They're tired of the complexity. They're tired of the waste. They want an accountable and responsive healthcare payment system, and I think this is it. I think we stand a chance of mobilizing a public that is ready to be mobilized. Technically, it's not easy. We'll have to figure this out. We're going to need waivers, Medicare and Medicaid waivers. We're going to need changes in certain federal statutes that apply to federal preemption in our state. Every one of those is solvable. And by the way, under the Affordable Care Act, which I've read, and I don't know if anyone else here has, there are provisions right in the Affordable Care Act that gives states the opportunity to do this in absolute, clear law. So we are at the threshold of real possible change right now. The pathway will involve planning. We'll have to get together. Starting day one of my presence in that corner office, we'll have groups working together to solve the technical problems en route, but I have no doubt we can get there.
All right. Don, I'd like to know where you stand on the issue of the referendum question that would eliminate casinos from Massachusetts, and what you think of that as a public health issue.
Thanks, Bill. I believe I'm the only candidate for governor of the Democratic Party opposing casinos. I'm against casinos, and I'm for the repeal referendum. I didn't come to that lightly. What I know is the data. I know what's happening in the dozens of states that have casinos now. DUIs go up, petty crime goes up. Communities are hurt. Local businesses are injured by the casinos that enter their areas. These are very large corporations coming into the communities, and they care much more about themselves and the communities they enter. But more than that, this is adding a mental health problem to this state. We are a state which has progressively cut its supports to proper mental health care at a time that it's costing us dearly. We have a substance abuse epidemic that we've got to deal with, confront, and solve and end. And in the middle of that, are we supposed to add a whole new burden of gambling addiction, which is well known, it hurts people, it hurts families, it hurts communities? That's not the trouble I want to buy. I think the negatives far outweigh any positives it seems, and I oppose them.
Jeff Walton from Concord.
Hi, Jeff.
Hi. So I'm a big fan and have watched you over the years and the Partnership for Patients and a number of the things that are happening through Medicare and CMMI, the Medicare and Medicaid Innovation Center, are dramatically improving the health of the populations and achieving the triple aim. We're talking about the payment mechanism, Medicare for All. What underneath that, and what are some of the goals maybe that you can help people envision what some of the better health would be as a result of that?
It's a great question. Let me decode some of what Jeff just said. CMMI is an important example of what you can do when you have an accountable public payment system. When the Affordable Care Act was passed, Congress allowed the establishment of the Center for Medicare and Medicaid Innovation, and I got to set that center up. It put aside $10 billion at the national level, and the reason that money's there is to support innovations, developments all over the country that have the effect of improving quality and lowering cost, and then taking those results, when they exist, turning them over to the Secretary, and allowing the Secretary of Health and Human Services to translate those into regulation directly. It's an engine for innovation and discovery now in American healthcare. And why is it there? Because there was a single payer that could invest in it. You can take that from the Medicare Trust Fund. We could do that in the state. If you, the public, owning the payment system now under a single payment system, said, I would love to see innovation thrive, new developments, better healthcare developing, we could do that. That investment's possible in the current system. It's very hard to achieve that. Now, in terms of the difference between changing payment and changing delivery, that is an absolutely key point. And as advocates, not just for single payer, but for better care in the Commonwealth, you need to understand that. If all we got was single payer to pay for the same healthcare system we have today, it wouldn't be what we're after. We'd still drop the ball with people with chronic illness. They'd be forgotten. Mrs. Jones would go home from the hospital, and she'd be back in 30 days because no one told her doctor at home what happened. We wouldn't have a fully integrated electronic medical record system so that the information can follow you. We wouldn't be investing in patient power, shared decision-making, where patients can make choices about what happens to them, really, really informed choices that always are better than choices made by others. We wouldn't be investing enough in prevention. Prevention is 400% more powerful, 400% more powerful in determining your health than is health care. And you'd think we might want to put some more into that. So there has to be an intention here. And the intention is to recreate the healthcare system itself. And that's going to involve change in the way the payments flow, change in what people have incentives to do. It's going to be really encouraging hospitals and doctors and nurses to think really hard about how to keep a hospital empty, not full. How to keep a machine off, not on. And by the way, it would allow us to enable a whole new healthcare workforce. Not just doctors and nurses, but advanced practice nurses, a whole new fleet of mental health professionals, people that really can help establish health in the communities. And that is what excites me the most about single payer. I want to get that money back. I don't like the idea we're wasting 8 or 10% of the dollar on administrative processes we don't need. But once we have that fixed, then I love the idea of accountability and innovation and investment into building the kind of healthcare systems we want in this Commonwealth. Massachusetts should invent the healthcare system of the 21st century for the entire nation.
And I work at Boston Healthcare for the Homeless. I'm just curious, what will it look like? I hope it will look something like, you're born in Massachusetts and you get a card, and that's it. That's all the administrative work we need. So I'd really like you to comment on that. And then also, if you could comment, do you think, Medicare isn't perfect right now. So would you want to think about a more perfect Medicare for all?
Yes. We can do much better. And I say that as a person that ran Medicare. What is it like? I heard it. If if you want to get confirmed by the United States Senate, don't mention another country. I got to warn you about that. But I remember reading something about Canada, coverage in Canada, and someone was trying to describe the healthcare. There you go. The healthcare coverage system in Canada, and here's the description of how that whole system works. Here's your care. That's what I'd like. You carry in your pocket now a card. It has on the top of it the name of an insurance company, one of others, and maybe has little codes that tell exactly what kind of copay deductibles you have, and if your neighbor has one, it's a different card. Now we all get a card. It says Massachusetts. Here's your care. You still have to pay for it. The money isn't going to come free, but finally we're going to have a single accountable way to invest in what we really want, and that is our health. What was your second question?
Medicare.
Oh, Medicare better. Yeah, well, the board of trustees of Medicare is the United States Congress. So in working with progressive legislators like Denise and Jamie Eldridge, who's endorsed me, and Sonia Chang Diaz, the first Latina senator in the history of the Commonwealth, is the chair of my campaign. There's a whole bunch of progressive legislators there that I would like to get together with right away and figure out what is the governance system that really that single payer should be under. I think it needs to be distanced a little bit from just direct political influence, but accountable enough that you can count on transparency, and when you need voice, you get the voice. And I think we could build that. I think it would be more responsive than Medicare is able to be right now. Plus, we're scaled differently. This is a state of, 6 million? At that scale, we can talk about communities, talk about the place we want to be. And I think the actual opportunity for developing this as a state level is in some ways more exciting, even than that it is at a national level. So I think we can make this work really well for us. And as governor, I'll tell you, there'll be no compromise in the excellence of the management that has to be
applied. Hi. I wanted to know your opinion on SGR and in your ideal Medicare for All, what formula you would use for physician reimbursement.
SGR is, we're in the weeds a little here, but let me explain, and correct me if I'm wrong. SGR is sustainable growth rate. Take me about an hour to explain it, but we'll try to. So what happened was Congress, concerned about the rising costs of Medicare, it said that the total amount of money being spent to pay doctors in the United States by Medicare couldn't rise faster than the growth of the economy, SGR, sustainable growth rate. So it said a decade ago, we won't pay doctors more than the growth of the economy. In the first couple of years, that was fine. And then came, I think it was 2003, and suddenly the payment to doctors total payment went higher than the growth rate. And Congress said to the Medicare, forget it, just pay them. But the law was on the books. And then the next year, it was still higher. They said, forget it, just pay them. And so the Congress kept kicking that can down the road, and it's ended up with a serious issue, which is now the gap between the statute, which is how much we're supposed to pay doctors in this country from Medicare, and the amount they're getting paid is enormous. It's 30% right now. Wow. So if we actually follow the law, there'd be an immediate cut of 30% of payment to doctors, and that would not make them happy. So when Congress has been searching for an answer to this, I'll tell you that the problem needs to be solved. We need doctors to be giving care. But the real problem here is being stuck in the fee-for-service payment system. We wouldn't have that conversation if we had where we need to head in this Commonwealth, which is away from fee-for-service payment and toward population-based budgets, global budgets, in which we can predict the amount of money available and it gets distributed the way we want to use it. That's part of the reform we need. Under a single-payer system, we get a chance to rationalize care and get out of that box. And it would be far simpler than trying to calculate all the codes that lead to payment in this very, very complex payment system. That's the direction we ought to move.
Peter Mork, I live in Austin. Do you have a specific plan or strategy for running this primary campaign? I get so...
the political campaign?
Yes. I get sort of frustrated. The local media has this sort of coronation mentality. I think Joan Bonacci wrote a while ago. It just in passing, Martha Coakley was expected to be the Democratic nominee. So that was some brilliant piece of wisdom just handed down from the mountaintops. It drives me crazy. But do you have a specific fundraising plan, or are you seeking specific endorsements that will help you get noticed?
I'm really excited to be in this race, and I'm not reading the polls right now, I'm talking to the people. And every place I go in this Commonwealth, the bold progressive agenda that I think I want to bring to this race is being embraced. People want a bold progressive in this race and the most progressive there. So I'm counting a lot on the resonance between people like you and the values that I'd like to project: social justice, compassion, equality. It's also important to be diligent and professional about it. I've got the best campaign staff anyone's ever had. And they are all over this Commonwealth. They're covering this every corner of the Commonwealth. There were about 600 and so caucuses in this state. We were at 580 of them. We know our delegate count, so I'm confident we're doing just fine. Thank you.
I'm a delegate for Don, and since he asked a provocative question, it's actually a great segue. Given what he just said, who's leading in the polls and what have you, the current Attorney General has been focusing her time on beating up on partners for trying to acquire South Shore Hospital. Why do you think she's turned her back to acquiring Neighborhood Health Plan?
Sorry, the last part.
I'll be more concerned about them acquiring a health insurance plan than I am about acquiring another hospital. So the partners just, took over Neighborhood Health Plan, which is an insurance company. All right? I mean, and shouldn't the Attorney General be focused on that? And what's your position relative to them moving into insurance? Somebody talked about the hospitals and the insurance companies. Now we got a system that's becoming both.
Yeah. Here's how I think about that question. The people that give health care in this Commonwealth, the organizations, they do want to help. They're doing their best. They show up every day to relieve suffering also. But they hit the pitch we throw. If we say the way to be a viable organization here is to keep your beds full, then they will do whatever it takes to make sure that they can stay in business by keeping their beds full. If we say, we'll pay you to treat a heart attack, but we really haven't got any money to help prevent a heart attack, then they'll go treat the heart attacks. So at some fundamental level, I don't blame the healthcare delivery systems of this Commonwealth for maintaining the system that exists now. I want to change the game, people. I want to change the game. I want us to create a public resource, single-payer resource, that we can then discuss as a democracy with respect to how we want those funds invested, and then go to the deliverers and say, this is how we would like you to behave. This is success for us. This is what it means to be successful. This is how you can make your money. This is what you'll be held accountable for. This is what we're going to measure as a result. If we change that game, then I don't care who acquires who or who's consolidated what. We're holding them accountable to produce the health and well-being that we want in this Commonwealth, and that's the missing conversation right now. Single payer will change that conversation, get us out of the box that we're in this kind of step-by-step guess about whether this is going to help or not. Let's get back to seeking help. That's what I want.
Very thankful for everybody who has questions. We're going to take 3 more. I'm sorry for those who are standing here. If you're smart, you'll wait for Don outside.
Paul Galvin from Dorchester, and proud to say that I'm a delegate to the convention for Don. I have about 5 or 6 points that I'll quickly run over, and there's a major point that I'll follow up. Under observation and admitted. Those are 2 key words, as you know, when somebody is admitted to the hospital. If a designation is made by the hospital that one is under observation, then you have an elderly patient whose bank account is robbed. The other person, and this was in the Quincy Patriot Ledger just a few months ago, people love to hear stories. I hope you talk about that. When you talk about not being allowed to talk about other countries when you're in government, Taiwan, South Korea, 2 examples of where we do not need to reinvent the wheel, where this has worked very well. When we talked about jobs and education, infrastructure, the American Society of Civil Engineers does a report every 4 years, and about 5 or 6 years ago, they had pointed out that we needed $2.5 trillion for our entire nation's infrastructure repair. 4 years later, they're saying it's now 3.6. For Massachusetts, I would recommend that you point that out. With interest rates being so low, Wall Street will be so happy to help with the bonding and the funding for a $20 million project that will have employment going across for the next couple of decades. I would urge you to meet with NAGE and Moses members, fully the Commonwealth of Mass. And since health is not a commodity, it is an essential of life, then that's how we should address it. And finally, we have the Treasurer, who is one of your opponents, leading with the Coakley and Company. He made a statement that with House Bill 59, which the Governor introduced, or proposed rather, that we send a strong message to the financial markets about Massachusetts' effective government and the future low interests for Massachusetts taxpayers by imposing 100% of health care costs on the backs of public employees in the future. Those are just a few thoughts.
A few. Are you available to run for lieutenant governor? A list of very important points. I'm not going to try to deal with all of them. I'll deal with. Let me just mention a couple of reactions I had to that wonderful analysis. This observation status thing. This is a derivative of a complex payment system that we need to simplify. You see, everyone's playing a game here. You pay for this, but not for that, and people figure out how to make sure that you do that and not that. So it makes no sense at all that if you're in a hospital and not yet sure you're going to be admitted, they keep an observation status, more comes out of the patient's pocket than if they actually go into the hospitals. It's just nonsense. It comes out of the complexity of a coding system. It comes out of the complexity of a payment system that comes out of a chaotic payment system. Let's make it make sense. Let's buy health. And we can simplify these conversations immensely and begin to focus in on actual delivery of what people need. Another rule, the 3-day rule. Someone comes into a hospital who should be in a nursing home. If they don't stay in the hospital 3 days, Medicaid can't pay for the nursing home. You want just the opposite thing to be happening, which is if you need a nursing home, why would you have to come into the hospital to prove it if they already know you need it? We have to get out of the games, and I'm attracted to single payer partly because it'll allow us to simplify. If we get the rules right, get the management right, it's going to be a far less opaque system. In terms of learning from other countries, let's learn from other countries. Our solution will be American. It'll be Massachusetts. It'll be different from any other place that's ever done single payer this way, but why don't we start looking and see what lessons have been learned in nations that are delivering better care at lower cost? Switzerland. The nation of Switzerland has healthcare costs at about 60% of ours. If we had followed the Swiss trajectory of healthcare costs in this country over the past 30 years, do you know how much more money we'd have to devote to other uses? $15.5 trillion. Wow. That's the difference between the second most expensive healthcare system on earth and ours. And by the way, Switzerland has the second longest life expectancy on earth. We're 40th. So there's some coming to terms here with what the data show, and I'd love to lead toward that. The last piece about infrastructure, this really matters. Our campaign is focused on the end of poverty. I will tell you that. You're going to hear that over and over again. There is no reason why a place this rich in knowledge and compassion and history should tolerate people who really can't get into the economy. That's not right. We need to end it. But ending it means we need to invest in it. I met a man 2 weeks ago, 30 years old, 4 children, and a partner, living tonight in a motel room because we can't come up with a $1,200 housing voucher to get that guy back into the housing market. Well, yes, we can if we fix health care. That will yield the resources that we need to draw on in order to be able to be compassionate, to be proper, to have justice with respect to the other investments we need to make. There's a tremendous opportunity here for realizing the kind of community we want to be in, and it has to involve healthcare reform.
This is going to be So what are ACOs going to look like under a single-payer system?
Oh, ACOs, okay. Among the properties of Obamacare that I oversaw was the implementation of a program called Accountable Care Organizations, ACOs. And it's a funny beast. When we have managed care, HMOs, HMOs work in part by restricting your choices. So they keep you in the network, and that way they're able to control the flow of care and assure quality, but also get costs under control. And people don't like it. A lot of people don't like it. I've always been in HMO, and I don't mind it at all, but many people want complete choice. So the ACO was invented, and it's a system in normal Medicare. It's just fee-for-service Medicare. But the providers of care can get organized, and if they're able to keep you in the network voluntarily, and your costs go down, and the quality stays the same or goes up, they save some money. They can share it. It's an experiment we put into place under Obamacare. It's producing some results now, but I've always looked at it as a kind of halfway experiment because we're trying to solve the problem of fee-for-service medicine, a heterogeneous payment system, and proper care for people in a very complex way. ACOs under single payer would thrive. They finally would have a way to have payment come from a single source that would be able to encourage them to have the care be organized and prudent, high quality, accountable, and transparent. So I think that basic idea, it would just get better and better once we simplify the payment system. And it's only one form of it. One more question?
Hi, thanks so much for coming. I'm a family medicine resident here at BMC.
Internal medicine?
In family medicine.
Family medicine.
And I have a question about the social determinants of health, which you've talked about a little bit. I think it was Representative Jackson who pointed out that there was a 30-year life expectancy difference between a black child born in Dorchester or Roxbury and a white child born in Back Bay. And I think that reflects global inequalities of racism and classism. How would you tackle that on a state level?
Keith mentioned the paper I wrote, the speech I gave called To Isaiah, and let me just tell you a couple words about Isaiah. I've disguised his name, but he was a 15-year-old boy who I met one morning when I had to rush into his examining room at the place I was officer of the day, and he was in severe pain, a black child from Boston, in severe pain, and I misdiagnosed him at first, but eventually we sorted out that night when I got a call from the laboratory that he had leukemia. Leukemia in a 15-year-old black child is a uniformly fatal disease, basically. It's very, very hard to treat. Not in a 5-year-old white, for reasons we don't really understand. Well, we went to the mat for him. We pulled out all the stops. I worked at that time for the Harvey Community Health Plan, an amazing place to work. We were a team. And we reached out to every resource we could get for Isaiah. And including a bone marrow transplant and the best possible care you can imagine. And we cured him. Between 15, it took 4 years, but by age 19 he was free of leukemia and it never came back. But that's only half the story. Isaiah smoked his first dope at age 5. He owned his first gun at age 10. He committed his first grand larceny at age 14. He was an amazing guy. We grew very, very close, and I think the world of this man, whose leukemia was cured, who died 10 years later on the streets, in despair, with lost in his ability to be welcomed into an economy with the kind of supports and mental health care and social services and reentry that he had 2 fatal diseases, you see. He had leukemia and he had injustice. And until we commit to building the kind of communities that we mean in the progressive agenda, a community that does not turn our backs, that does not walk past that person on the street with his cup held out, or a child who's hungry tonight, until we decide not to walk away from them, curing disease isn't in our hands. We have to be able to go back to the basics, and the basics have to do with a society that's equal. Equal. All means all. And if we have a payment system in healthcare that allows us to move toward thinking about health as investment, as a community, all in it together, it's all our money, then we can change, we can decide that we'll cure both diseases, both leukemia and injustice, and that's the way I think we should head.